Alright, so we're now near the end of NBME 20. This video and the video after this will basically be the two-part breakdown of finishing up NBME 20, Block 4. So I'm going to do 25 questions right now, and then another 25. I realized that this is actually really intense stuff. Like, when I was studying for my own Step 1, I don't remember really getting through 50 questions a day, to be honest, with explanations and everything. And doing it in this manner where, I'm not like stopping or, getting distracted or anything because I'm recording for a video, it's been pretty intense. I usually feel really, really burned out when I'm done. And it's not easy getting through 50 questions, talking about their explanations. So it's been pretty fun. I feel like it's a great way to study too. Like if I was actually preparing for my own Step 1 right now, I feel very confident for the Step 1 in general. Because there's, when you're doing NBME questions, the questions are all over the place. They're just jumbled, mixed up, systems, principles, everything. So your mind has to work on multiple things at the same time rather than just you doing questions like by system and stuff, which is fine in the beginning when you first start studying for Step 1. You do UWorld, you do questions just by system. So there's that. Now, after the 25 questions right now, I'll just take a 10-minute quick break, just get something to eat, and then I'll be right back. And then we'll do the last 25 questions, and that'll be the 200 questions of NBME 20. So let's get this one started. Number one, a 65-year-old woman who has a 25-year history of chronic alcoholism is brought to the emergency department because she's vomiting blood. She eats little more than an occasional sandwich. Examination of the legs show perifollicular hyperkeratosis and hemorrhage. Abnormally decreased function of which of the following metabolic pathways is most likely in this patient. So basically we have an alcoholic patient and we're trying to figure out what's not working in them. And a lot of things don't work anymore, especially anything that requires NAD+. When you look at alcoholism, it's the first thing right before metabolism, right? Ethanol metabolism. I don't know why metabolism starts here, even though ethanol metabolism, it's still a part of metabolism, but they have it in nutrition. It might be something they'll change up, but either way, it's on the same page. So in ethanol metabolism, what you're supposed to learn is that all pathways that require NADH runs out, right? You can't do them anymore because you used up all your NAD plus here. Sorry, what am I saying? All the pathways requiring NAD plus, like I said originally, you can't do them anymore. You can't do them anymore. So for example, right here in the TCA cycle, you can't do any of those pathways that require NAD plus, the positive thing. I always remember that with not drinking is a positive thing, right? So if you're not drinking, you have the positive thing. If you drink, you lose the positive thing, right? Because all the people that are drinking, all the alcohol that you're metabolizing, you use up your NAD plus and make a shit ton of NADH. So you no longer have NAD plus if you're a chronic alcoholic. And when you run out of NAD plus, you can no longer do a couple things. So all your body systems kind of shift toward things that require NADH. So you can't do your TCA cycle because there's multiple parts that require NAD plus, right? You end up taking pyruvate to lactate because that requires NADH, so it's a preferable pathway to go. Your acetyl-CoA goes into making keto acids and fatty acids because all of it is shunted that way since it cannot go into TCA anymore. And then your oxaloacetate over here, it's supposed to give you PEP, right? So you can keep going this way. Instead, you run out of oxaloacetate and you make more malate. All right, so this is another pathway that works with NADH. So a lot of things that occur here, often get tested. You can get silly questions about any of this stuff. Right, and it's really important to make sure you understand how NAD plus is the limiting reagent and how that leads to the symptoms you see in chronic alcoholics, the ketoacidosis and the hepatosteatosis. You can see all of that in this really nicely done diagram that First Aid has. Now this question though, it doesn't talk about any of that, right? This question, the main thing when you get nice questions like this, what you really want to focus on is the examination, Alright, so the examination is the main focus because that's how you're going to diagnose somebody. So the examination, they're talking about perifollicular hyperkeratosis and hemorrhage, which really rings a bell for some kind of vitamin deficiency because that's what your acid traces are kind of looking like, right? This patient is unable to do one of these many things. So then you start looking at every one of these acid traces and they should all ring a bell for something. So hydroxylation of proline, synthesis of porphyrin, right? Okay, you can knock out acid trace E because you know this is not a porphyria, right? This is definitely not a porphyria. This patient has hyperkeratosis and hemorrhage. Those are not really symptoms of any porphyria, so you can knock that out. Carboxylation of pyruvate, that, when you read that, you might think it's possible. Decarboxylation of pyruvate, now you're like, okay, wait, why do we have two acid traces that are both about pyruvate? Maybe one of them is the acid choice. C should just be something you knock out because you've never heard of it, like decarboxylation of 2-keto-isocaproic acid. Not really relevant to any of the vitamins that we've done. And then hydroxylation of proline. And you know that hydroxylation of proline is related to making collagen and stuff like that. So this patient, their 65-year-old patient with chronic alcoholism, her presentation is actually a vitamin C deficiency. She has scurvy. Scurvy features swollen gums, easy bruising, petechiae, perifollicular and subperiosteal hemorrhages. Right? She had perifollicular hemorrhage, but they really tried to make the confusion here by just saying perifollicular hyperkeratosis first. And she has perifollicular hemorrhage, but some people might not read that in that manner. So the perifollicular hemorrhage is usually a giveaway for vitamin C deficiency, and vitamin C is necessary for hydroxylation of proline. So that's all this question was about. This is a question that a lot of students did get wrong when I work with them and do it, because it's a little difficult to sometimes combine and understand things in this manner because you might not have actually studied it like that. Right, so this is vitamin C deficiency, scurvy, and they tell you perifollicular, subperiosteal hemorrhages. Right, you're supposed to have perifollicular hemorrhages, and that's what that patient was having. You also end up having a weakened immune system, but she was already 65, so her immune system is also already weakened to begin with. They didn't give you any other symptoms, which is very common of NBME type questions. They won't tell you shit, basically. But it's really nice to know vitamin C deficiency because it's usually an easy question, but it can become really difficult if you forgot the things related to vitamin C. So make sure you pay some time to that too. Number 2, a 33-year-old woman with HIV is brought to the emergency department 30 minutes after she had generalized tonic-clonic seizure. She also has a 2-month history of daily headaches. Physical exam shows no signs of meningismus, okay. Muscle strength is 3 out of 5 in the left upper extremity and 5 out of 5 in the right upper extremity. Her CD4 T lymphocyte count is 22, which is on the very, 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 very low end. And plasma HIV viral load is 50,000 copies per milliliter. Alright, so CD4 is pretty much 0. A CT scan of the head shows a 3 centimeter lesion in the right cerebral cortex. Serologic studies show a positive IgG antibody titer to Toxoplasma gondii. Okay. Treatment with pyrimethamine and sulfadiazine is initiated, which is the right treatment for toxo. During the next 2 weeks, she has 3 additional seizures. 2 weeks after starting antibiotic therapy, a CT scan of the head shows that the lesion has increased to 3.5 centimeters. Which of the following is the most likely cause of this mass? Okay. So she has a abscess, and remember with toxo, you want to think of like ring enhancing lesions, right? That's another thing that you have to keep in mind. So toxoplasma happening is usually something that is a big sign of immunocompromise, and she is HIV positive. So she started treatment, but her things just started getting bigger, right? Her lesion got bigger. So you look at all your acid choices, try to figure out why is it getting bigger. So you see bacterial abscess, you see cerebral toxoplasmosis, which a lot of my students were very keen to pick, glioblastoma, metastatic disease, and non-Hodgkin lymphoma. So this one was actually slightly difficult of a question. I have to say I don't see why people wouldn't get it wrong. I get it. So this was actually PCNSL. This is a primary central nervous system lymphoma, most commonly associated with HIV and AIDS. The pathogenesis often involves Epstein-Barr virus infection. Remember that in PCNSL, the peripheral smear shows atypical lymphocytes that are actually infected B cells, while the same smear in Epstein-Barr virus, that atypical lymphocyte is a reactive T cell. And I'll show you what I'm talking about. We talked about it before too. Considered an AIDS-defining illness, variable presentation with confusion, memory loss, seizures, mass lesions may be ring-enhancing in immunocompromised patients on MRI. Needs to be distinguished from toxo via CSF analysis or other lab tests. Toxo usually has multiple ring-enhancing lesions. So what happened in this question was, this patient got toxo and you already treated it. Now, the lesion that she has that's getting bigger is not because of toxo. That was the number one thing you needed to understand first, at which point you would knock out answer choice B. Because you already treated the toxoplasma. You gave the patient the medications she needed. She's not going to have toxoplasma anymore, but she still has this one singular lesion that's getting bigger. That is PCNSL, which occurs in HIV patients. And this is discussed on page 462 over here. So on your PDF, or the actual FA 2019 is 422. Peripheral central nervous system lymphoma, most commonly associated with HIV, an AIDS-defining illness, blah, 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 as we discussed, right? It needs to be distinguished from toxo. So if you do see a question about toxoplasmosis, keep in mind that toxoplasmosis and PCNSL have a lot of overlap, but there's a major difference between the two. Toxo causes multiple ring-enhancing lesions, right? So there will be more than just one, whereas with primary central nervous system lymphoma, the primary should help you remember there's only one. Right, and the atypical lymphocyte I was talking about, so you can get this peripheral smear. You can get this exact peripheral smear for a question about PCNSL. If the question is about PCNSL and they ask you, what is this atypical lymphocyte? That is actually a infected B cell, all right? But if you have a question about Epstein-Barr virus, and then they ask you, what is this reactive or atypical lymphocyte? This is actually a reactive T cell. Even though Epstein-Barr virus actually infects B cells using CD21, the B cells don't look different. They don't have any kind of reaction or anything. So in Epstein-Barr virus, this would actually be a reactive T cell that's trying to get ready to fight Epstein-Barr virus. Whereas in PCNSL, this is an infected lymphoma B cell. Alright, so very important to remember that little difference. You can get very easy giveaway questions on it, so don't mess that up. And anytime you see a question about toxoplasmosis, think of PCNSL and try to figure out the difference. It's almost always going to be an AIDS patient for both things, but the toxo can be treated with medications, and toxo will usually have multiple ring-enhancing lesions, whereas PCNSL cannot really be treated with just the same medications, and it's going to have one ring-enhancing lesion like this patient did. Okay. Number 3, a 16-year-old with cystic fibrosis is brought to the physician because of a 3-week history of generalized weakness, numbness, and tingling of her arms and legs, and difficulty walking. Okay, so that's a lot of things happening to this 16-year-old with cystic fibrosis. This first sentence was very dense to begin with. She has not adhered to her medication regimen during the past 6 months. She appears alert and oriented, vital signs are within normal limits. Physical exam shows bilateral weakness and decreased deep tendon reflexes in the upper and lower extremities. She walks with an ataxic gait. She most likely has, the most likely cause of these findings is a deficiency of which of the following. So then you think of cystic fibrosis and you remember that people lose their fat-soluble vitamins in cystic fibrosis. So you're going to be thinking between K, A, D, and E. So you can knock out A and C as your answer choices. Now, her symptoms are very similar to that of vitamin B12 deficiency, right? She has the tingling, the numbness, the ataxia. Vitamin E deficiency and vitamin B12 deficiency are very similar. And in this case, they didn't put vitamin B12 as an answer choice anyway. So the answer was just vitamin E. Right? Vitamin E loss can cause demyelination of your posterior columns, which causes a loss of your position and vibration sense, and a demyelination of the spinocerebellar tract, causing ataxia. Right? So page 70. Let me see. So we come over here, see vitamin E deficiency. Neurologic presentation may appear similar to vitamin B12 deficiency, but without the megaloblastic anemia, without the hypersegmented neutrophils, and without the elevated serum methylmalonic acid levels. All right, so those things don't happen to be elevated in vitamin E deficiency. But vitamin E deficiency does have demyelination of posterior columns and the spinocerebellar tract, whereas vitamin B12 deficiency had that subacute combined degeneration, right? And that's up here, vitamin B12. Right, so vitamin B12 had subacute combined degeneration where you lost the dorsal column, the spinocerebellar tract, and the corticospinal tract, right? But not the spinothalamic tract. So temperature sensation is not affected here. Your spinocerebellar tract is a different thing. So you want to make sure you know the tracts. You want to make sure you know what the symptoms are, and you should be able to associate the differences between the two. And the megaloblastic anemia is a big difference between B12 and vitamin E deficiency as well. She didn't have symptoms of anemia, so they didn't even put vitamin B12 as an answer choice. But vitamin B6 is always a trick answer that's always there for people who might not really be able to catch what the issue is. This was a pretty straightforward question given the cystic fibrosis and the ataxia. But vitamin B6 is usually that one vitamin that kind of can be related to anything. When you think of vitamin B6 deficiency, there isn't a very specific symptom you think of. That's because B6 deficiency is related to so many different things. And so if we go up to vitamin B6, you see, called pyridoxine, converted to pyridoxal phosphate, and it's a cofactor for many things, and it's responsible for the synthesis of a shit ton of things. So you can get symptoms related to almost anything depending on what you're really missing. So B6 is usually that mysterious answer choice for the question where you really can't figure out what's causing it. What deficiency is causing the symptoms you're seeing. Number 4, so this is a 61-year-old man has erectile dysfunction due to spinal cord injury at L2. Sildenafil is likely to markedly correct the dysfunction by acting at which of the following labeled structures in the transverse section of the penis. So you're basically being asked, where does the blood cause erection through? Right? You look at this image, you have your dorsal artery, you have these two guys, and then this bottom part down here. And it's very evident that these two guys are the ones that are going to cause the erection to occur. So page 716 discusses sildenafil. I have more pictures there I'll show you. Phosphodiesterase 5 inhibitors are indicated for erectile dysfunction by way of increasing blood into the corpus cavernosum, which is labeled D here. The deep artery is the artery to the corpus cavernosum, and that's the artery that you're going to fill up. So, is this page 716? So let's take a look at another image that kind of helps you better understand what's happening there. So if you look at this one right here, there's a bunch of arteries that are being shown really nicely. So you have your dorsal artery that was labeled, right? And then you have this one going inside, right? And on the bottom there's a couple arteries as well. You have your bulbous branch, the anterior branch, the corpus spongiosum was in the image also. This is your corpus spongiosum. The spongiosum isn't the one that you're really trying to help. The one that you're really trying to help is called the deep artery. The deep artery is the artery to the corpus cavernosum. Right? It's not labeled in this image, but this image does a good job to show you that all the blood is coming from the internal pudendal. Right? So that's a nice little anatomy to know because the rest of it is already well known. The book teaches you blood flow goes into corpus cavernosum. This also helps with pulmonary hypertension. Remember that you can give this medication to reduce pulmonary vascular resistance as well. And yeah, that's all this question was about. But it was interesting to see. A lot of people picked A, some people did pick C, but majority did know that it is D. And it definitely could not be B, so that's pretty much just the outer area. That's not where the blood is going to flow. And that was about it for that question. 35-year-old man is given cyclosporin following a liver transplantation. Which of the following mechanisms best describes the utility of this drug in this situation? So basically, what is the mechanism of action? So if you look at all the answer choices, decreased synthesis of interleukins, induction of calcineurin phosphatase, inhibition of B lymphocyte proliferation, you can cancel that out because that wouldn't really help with liver transplantation issues. And that's definitely not how this medication works. Promotion of internalization of tumor necrosis factor alpha receptors, that's also completely irrelevant. Stabilization of lysosomal membranes, also irrelevant. So you're really between A and B, and you really need to remember these guys very, very well. Cyclosporin is a calcineurin inhibitor that binds to cyclophilin and aims to decrease interleukin 2. Tacrolimus also inhibits calcineurin, but it does so by binding to FK506 and decreases interleukin-2 as well. Sirolimus is an mTOR inhibitor, which is often something that is, mTOR is a really high-yield topic lately, not for step 1 per se, but in the real clinical world, because mTOR is something that people are relating to becoming immortal in a sense. It's a very interesting thing. And sirolimus is an mTOR inhibitor that binds FKBP as well, and blocks T-cell activation and B-cell differentiation by preventing a response to interleukin-2, but you're still making interleukin-2. So if you remember your hot T-bone steak stuff, right, interleukin-2 is the one that's related to that, let me show it to you. Immune, let's see, yeah, right here. So if you look at this, you need to know all these guys very, very well. And hot T-bone steak, so the interleukin-2 was the one related to T cells, right? And T cells are related to transplantation stuff and rejection. TNF-alpha was also one of your answer choices. This thing is more for granulomas, right? Activates endothelium, causes white blood cell recruitment vascularly, causes cachexia and malignancy, the weight loss and all of that you see in cancer patients, and maintains granulomas and tuberculosis. All right, but that had nothing to do with our question. This question was all about interleukin-2, and the medications are discussed on page 120. Those medications, there's something significant you need to know about them, so you need to remember them really well, especially these first three. Cyclosporin and tacrolimus both prevent interleukin-2 transcription, so you run out of interleukin-2, whereas sirolimus prevents a response to interleukin-2. Now, a couple of these you can combine and some you can't. Both calcineurin inhibitors, cyclosporin and tacrolimus, are highly nephrotoxic, especially in higher doses or in patients with decreased renal function. So if you look at cyclosporin, you want to think of a spore. I wrote here, spores are hairy. So imagine cyclosporin to be hairy, and remember that it causes gingival hyperplasia and hirsutism. Tacrolimus doesn't cause those things, but it and sirolimus both cause diabetes. So basically, if you look at tacrolimus, it says that it has an increased risk of diabetes, right? And sirolimus, which is also a limus medication, causes insulin resistance, which is also diabetes. So you cannot give tacrolimus and sirolimus together. But you can give cyclosporin, right? They tell you here, synergistic with cyclosporin. You can give cyclosporin with the sirolimus. That you can definitely do. You can't give cyclosporin and tacrolimus together either, because one, it would be pointless. They both do the same exact thing, same exact mechanism of action, and they're both very nephrotoxic, so that's not a good idea. But cyclosporin and sirolimus can be combined. Alright, so you want to make sure you spend some time getting that down. The latter half of this page is the easier stuff. You already know glucocorticoids, you already know azathioprine, so all you need to do is catch basiliximab, which just blocks interleukin-2, and mycophenolate mofetil. This is just a lupus nephritis thing, alright, indication. This is just a medication you give for lupus nephritis. So not the most difficult things, but here the answer was decreased synthesis of interleukins. It was really easy to figure that one out, but a lot of people could pick induction of calcineurin phosphatase, but the correct thing is inhibition of calcineurin. You're not going to have calcineurin. They're calcineurin inhibitors. Alright, so it was just answer choice A. Number 6, a 45-year-old man comes to the physician because of intermittent bloody diarrhea and abdominal pain during the past month. Sigmoidoscopy and rectal biopsy specimens show inflammatory bowel disease. Okay, so 45-year-old with inflammatory bowel disease, bloody diarrhea. So you should really know what's happening here. A trial of a monoclonal antibody preparation is begun. The antibody in the preparation is most likely to be directed against which of the following components? And then you look at all your answer choices: bradykinin, C3A, class 1 antigens, fibrin, prostaglandin, or TNF. And if you don't know what's happening here, then this is related to the immunology of inflammatory bowel disease. The answer here was tumor necrosis factor. Drugs like infliximab, adalimumab, and many others are actually monoclonal anti-TNF-alpha antibodies that are used for IBD. If you remembered that, then you would know what the answer is. Before administering, you need to test for latent TB, because if you give TNF-alpha inhibitors, then remember, we just said it, that TNF is responsible for taking care of your granulomas. So if we go to our inflammatory bowel diseases, which you should know the differences between really accurately, Crohn versus UC. So, Crohn is the one that has your skip lesions, rectal sparing. It's a disease, remember. So Crohn disease is a disease. There's many things happening there. Whereas ulcerative colitis is just a colitis. There's just inflammation of your colon, right? This one is the one that's Th2 mediated, whereas Crohn is Th1 mediated. And you have to remember that difference. There's many other things to it, but if you come down to treatment, right, you can see infliximab, adalimumab, infliximab. You can give it for either one of them. And those guys are your TNF-alpha inhibitors, right? So that's another immunology topic. This is a question basically about immunology. Alright, number 7. A 78-year-old man dies of chronic congestive heart failure. Examination at autopsy shows chronic passive congestion of the lungs, hypoxic changes in the brain, and hydropic change of the renal tubular epithelium. This word of hydropic change is a really specific thing. Which of the following is the most likely cause of the hydropic change? Oh, okay, so of course the question is about that too. So you look at your answer choices. First, you got to figure out 78-year-old with congestive heart failure, right? And he dies. Examination of autopsy is showing many things, but all they tell you about the kidney is hydropic change. So you need to understand that something didn't work anymore, right? That's the first thing that's happening. The person died. Any change you see in an organ after someone dies is because something stopped working. And the congestive heart failure wouldn't really be related to that hydropic change so much per se. So you look at your answer choices, calcium release from mitochondrial stores. That can't really be related to hydropic change. Like calcium release from mitochondrial stores is usually more so related to like the contraction of muscle. Okay, increased intracellular H+ concentration. So that would be acidosis, which wouldn't cause hydropic change. You really need to know what hydropic change is too, though. Interference with protein synthesis, loss of plasma membrane integrity, those two things kind of go hand in hand. That's not it either. Hydropic change is kind of like a swelling. Right? Swelling of the cell is hydropic degeneration. That comes from tissue ischemia, which occurs in this patient. He had CHF and he died. Tissue ischemia leads to decreased ATP production, which causes failure of the sodium-potassium pump, right, and the calcium pump activity, causing a diffusion of sodium and water into the cell, leading to cellular swelling. This is a really important thing that is part of the pathogenesis of organs dying. That's kind of something you have to know really well. Calcium release from the mitochondrial stores is not really a big thing. If it was just calcium release in general, or like calcium pump activity, then that could also be a valid answer choice. But I can see how a lot of people would pick that answer choice. And if you go to, well, it's not in the book, but let me show you. If you discuss how things happen with MIs, you can see there was this question about MIs. So if you look at this question from UWorld, it says, in experiments, transient MI causes myocardial cells to increase in size. That's also hydropic change. Right? Myocardial cells increase in size. This effect is due in part to which of the following? And then these were your answer choices. Intracellular potassium, intracellular calcium, high cellular bicarb, cascade protein phosphorylation, or net cellular solute loss. All of which, a lot of them seem very plausible. So 21% of people actually chose potassium, but the correct answer was calcium. Right? Without ATP, the sodium-potassium ATPase stops working, and the sarcoplasmic reticular calcium ATPase also fails. All of this leads to more intracellular sodium and calcium, because potassium is going to stay outside, and increased intramitochondrial calcium concentrations. These things attract free water, causing cellular and mitochondrial swelling. Right, so now if you compare that to what's happening here, let me just make this bigger. Right, so okay, it wants to be difficult. So if you compare this question to what's happening in our question right now, it's pretty much the same stuff, right? And this answer choice, calcium release from mitochondrial stores, right? Which of the following is the most likely cause of hydropic change? The cause is definitely not calcium release. If the calcium was stuck inside the mitochondria, though, that would be a cause, right? So that's what we see in this explanation here, right? Increased intramitochondrial calcium concentration. If the calcium is stuck inside the mitochondria, or the sodium is stuck inside the cell, right, without the ATP, then you would have more sodium and more calcium inside the cell, causing edema. Sodium potassium ATPases normally bring potassium into the cell, and in ischemic tissue, intracellular potassium is decreased. In fact, the potassium is all stuck outside, and it can cause arrhythmias. Right? So you have accumulate extracellular potassium, which can cause arrhythmias. Okay, so really important to make sure you understand that. That thing about the heart is actually true about other organs too. All organs, generally speaking, are surviving the same way. Okay, it's a really interesting way to look at that topic, and you can see how you have the same exact topic, but about different organs. So it's all the same stuff. And hydropic change isn't that far-fetched. It is a pretty common way to describe things. So make sure you know that hydropic change is like hydro, water. So it's just edema. 37-year-old man who is HIV positive comes to the physician because of a 3-week history of severe pain in his legs and pain, numbness, and tingling in his feet. So 37-year-old HIV, pain and numbness. He's receiving antiretroviral therapy. On physical exam, the soles of the feet are tender to palpation. Sensation to pinprick is decreased over his calves and feet. Which of the following drugs is the most appropriate for long-term relief of his pain? So what we're seeing here isn't actual pain though, right? It's more like neuropathic pain. It's very similar to another kind of neuropathic pain you can also have in diabetic patients. He doesn't have actual pain from like a trauma or something like that. So you start looking at your answer choices. You want to pick one that's not something you would give to someone with neuropathic pain. Or pick all your answer choices that are related to giving someone something for actual pain. So for example, acetaminophen is something you would definitely take after trauma pain. Hydrocodone for sure is something you would take after trauma pain. Methadone as well. Naproxen is another form of acetaminophen basically. So that just leaves you with nortriptyline, which is actually a TCA, and you just pick that, right? Also, hydrocodone and methadone can lead to dependence, so you avoid in long-term use. And his thing, which is neuropathic pain, it would require long-term use. NSAIDs, you also avoid due to partial ineffectiveness in neuropathic pain, as well as also risk, mainly the naproxen. Acetaminophen is a very unique medication. You want to make sure, let me just revise that one more time with you guys, because acetaminophen is a very unique thing. This guy it's an NSAID, but I don't really refer to it as an NSAID. It reversibly inhibits COX, mostly in the CNS, inactivated peripherally. So this can be used in patients with peptic ulcer disease, right? It doesn't do anything in your stomach or anywhere else really. Antipyretic, analgesic, but not anti-inflammatory, which is why you can go ahead and say it's not exactly an NSAID, right? NSAID is non-steroidal anti-inflammatory drug, but this is not anti-inflammatory. So acetaminophen is very unique. A lot of people think of acetaminophen with NSAIDs, so every time you think of NSAIDs, acetaminophen falls in that category too for most people, but it's not. Alright, so make sure you remember that. You can give acetaminophen to a person who does have risk of peptic ulcer disease. It doesn't do anything to cause more peptic ulcers. These are your actual NSAIDs, ibuprofen, naproxen, all of these guys. And then TCAs are known to treat neuropathic pain very well, either in diabetes or antiretroviral therapy. Right? TCAs are discussed on page 622 over here, so let's take a look at that too. Alright, so that's 563 in psychiatry. TCAs, right? Amitriptyline, nortriptyline, imipramine, desipramine, all the other pramines, doxepin, and amoxapine. Right? They don't all have the same kind of name, which is usually pretty annoying, but they all inhibit serotonin and norepinephrine reuptake. And you can see you can use this for chronic pain, right? Chronic pain right here. So, and peripheral neuropathy. And if you combine peripheral neuropathy and chronic pain, that's pretty much neuropathic pain. So it helps with that really, really well. Know the side effects, know how it works, know that the treatment for what do you call it? The not exactly an overdose, but the cardiotoxicity, I guess, is to use sodium bicarbonate. Right? And there's a really big deal about how sodium bicarbonate helps, so you need to make sure you know that too. That's also discussed when we get to psychiatry videos. I'll talk about it, but in my previous psychiatry videos, I've discussed it as well. Right, so really good to know those medications pretty well. So that was one way of tackling it. The other way of tackling it was what I've been mentioning throughout my NBME stuff, right? Using logic, which one of these is most different from the other. And nortriptyline is the most different medication of these 5 medications. The other 4 guys are pretty similar. Nortriptyline is very different compared to the other 4. In fact, if you just think about first aid itself, nortriptyline is a whole different chapter. The other 4 guys are in pretty much the same chapter. It's really important to make sure you know that kind of like logical application. It can help you knock out a lot of answer choices. Number 9, a 62-year-old man comes to the physician for a follow-up exam. 2 weeks ago, he was discharged from the hospital after sustaining an acute MI. He smokes 2 packs of cigarettes and drinks 4 12-ounce beers daily. His diet mostly consists of cured meats and fast food. He doesn't exercise. Patient tells the physician, I know that I need to make some changes in how I live so that my heart can be healthier. I just don't have the willpower to quit smoking and drinking and all that stuff right now. Which of the following best describes this patient's stage of behavioral change? Now, when you study pre-contemplation, contemplation, all of that stuff, and you look at it in the book, and you're like, all right, cool, I get it. It's not that hard, and you feel like you're always going to be good at it, but it can be difficult. It can be difficult, especially when the question is about pre-contemplation versus contemplation. So in the first stage of overcoming addiction or pre-contemplation, the patient denies the presence of a problem. Make sure you remember that and it becomes easier. Pre-contemplation means you haven't really started getting to contemplation yet. Contemplation is the stage where you acknowledge that there is a problem, but you're not ready to make changes yet. Right? And the preparation is where you're getting ready to make changes. Action is where you actually make the changes. Then in maintenance, you make sure you don't quit and go back to where you were. Right? That's the thing you want to remember. So this guy who's saying, I know that I need to make some changes to be healthier, but I just don't have the power to do it yet, that is contemplation. Right? That is a lot of my students wanted to pick pre-contemplation. Some students were saying preparation because it looks like, and it's really easy to convince yourself into picking an answer choice. That's another thing you want to be careful of. So if you think the answer is preparation, you might be like, well, yeah, he's preparing. He's saying he has a problem. He's saying he needs to make changes. He's actually mentioning the changes he needs to do, which is eat better, work out more, right? He just doesn't have willpower. Sorry, not eat better, work out more. He's saying he needs to quit smoking and drinking, right? And all that stuff right now. So he needs to quit all that stuff right now, and he's preparing. You can convince yourself into saying that, and that's not what's happening. That is not preparation. That's contemplation. That's you kind of figuring out what you need to do, right? But you haven't started preparing it yet. Preparation would be actually making like a list of how you're going to quit. How are you going to quit smoking? Okay, I'm going to try the patches and then slowly wean off. How are you going to quit drinking? Maybe I'll cut down to maybe 2 beers a day and then 1 beer a day, and then just, slowly just give it up, use some kind of medication maybe, meet a psychiatrist that can give him medications for quitting alcohol, quitting smoking, stuff like that. That would be preparation. This isn't preparation. This is contemplation. And the pre-contemplation, basically saying that you don't even know there's a problem yet. Right? So that's the thing. Denying the problem, or presence of a problem. So really got to make sure you know how to differentiate those things, because you really don't want to get a question about that stuff wrong. That should usually be a giveaway question, right? Stages of change in overcoming addiction. Pre-contemplation, denying the problem. Contemplation, acknowledging a problem, but you're not going to change. Preparation or determination is preparing for behavioral changes. So this is where you're figuring out how you're going to do it, right? And actually making some kind of advancement towards quitting. Action and willpower are actually changing the behaviors. That's when you started changing. You stop drinking, you stop smoking, you cut back maybe, stuff like that. Then there's maintenance. You stay that way, right? And then hopefully you won't go into this 6th phase, which is relapse, returning to old behaviors and abandoning all these changes, which is a very common thing. Right? So make sure you don't mess up this kind of question. This is like a giveaway stuff. No actual medicine or clinical knowledge or math involved. So make sure you know it. A 12-year-old boy is brought to the physician for further evaluation because of 3 episodes of meningococcal bacteremia during the past 4 years. He has had no other significant infections. Physical exam shows no abnormalities. The most likely cause of these recurrent meningococcal infections is a deficiency of which of the following. So you have to remember there's only one thing that causes recurrent Neisseria. Right, recurrent Neisseria, and didn't say recurrent Neisseria because that might ring a bell, but it's the lack of your terminal complement. Right, terminal complement disorders, or lack of terminal complement, which is C5 to C9, causes an increased susceptibility to recurrent Neisseria bacteremia. Patients most often present with recurrent meningitis. So we go to page 107 now. Complement disorders. Right, early complement deficiencies are related to lupus. In lupus, you have low C1 to C4. Mainly C3. In terminal complement deficiencies, that's a recurrent Neisseria. Right, C5 to C9, you won't be able to make MAC. And MAC was the guy that was necessary for Neisseria, to treatment of Neisseria, especially if you're doing sketchy micro. MAC is actually the detective that's actually going around looking at the Neisseria patients and figuring out what happened. So really good to know that stuff. Know these 2 guys too. This page doesn't have much. Right, C1 esterase inhibitor deficiency, where you can no longer inhibit C1 esterase. This causes you, right? C1 esterase is the guy that causes you to have more bradykinin, right? Unregulated activation of kallikrein, leading to more bradykinin, characterized by low C4 levels. And since you have so much bradykinin in you, you cannot give these patients ACE inhibitors because then they'll have even more bradykinin, and then they're going to get the symptoms of coughing, the dry cough. PNH is just a lack of one of 2 things. So it's a defect in PIGA. You're either going to be missing the anchor, the GPI anchor for complement inhibitor, or you're going to be missing the decay accelerating factor. Right? So what do they tell you here? Defect in PIGA gene, formation of GPI anchors for complement inhibitors such as, these 2 guys, right? Decay accelerating factor or the membrane inhibitor of reactive lysis. Right? If you're missing CD55 or CD59, and then whatever their long names are, you end up getting complement-mediated intravascular hemolysis. It's paroxysmal, and it's nocturnal, and it causes you to have hemoglobinuria. You're going to have low haptoglobin, because haptoglobin is going to be going around binding all the hemoglobin. Right? So you run out of haptoglobin. It's binding all the free hemoglobin, and you're going to have dark urine because you're bleeding. You have hemolysis. Really interesting disease. Most questions about this are just going to ask you about CD55 or 59, so you should remember that. Nothing else. I've never seen a question on PNH that was hard. That's how I'll put it. So you just got to make sure you know what PNH is. All right, so remember these guys. It's just 4 simple disorders that don't have crazy pathophysiology or anything. And if you do recall them, then when you get a question, you'll be able to associate the problem with it. So that was this guy, terminal complement disorder. Alright, so now here, this was a little bit of an annoying question. Number 11 is an anatomy question of the leg. 33-year-old man comes to the physician because of a 3-week history of pain in his right thigh, especially when walking. There's no history of trauma. Physical exam shows mild swelling but no erythema, so there's no inflammation. The MRI shown depicts a tumor while white on T2 weighted signal in an anterolateral muscle of the thigh. So that's the tumor right there. Right? Anterolateral. Which of the following muscles is infiltrated with this tumor? And that anatomy aspect was the piss off, right? So if we look at this picture, right, same area right here, so that's right here. Right, and it's infiltrating your rectus femoris. You can see because your rectus femoris is right here, right, and that's your tumor in the same exact area. This is the other muscle, the big guy, vastus intermedius, and this is the bone that we're seeing right here. So your tumor is over here, and that's your rectus femoris, but you might not actually remember this anatomy of the muscles of your feet. So there's really no true way to get this question correct. You can knock out A because an adductor muscle would be medial, right? Adducting means adding your legs together, and this is not a medial muscle. Gracilis, again, look, gracilis is in the back, right? You have to remember, to some extent, you should remember like the compartment of where the muscles are. You don't need to know exactly where they are, but is it in the anterior compartment, posterior compartment, medial, lateral, etc.? You should remember that. And gracilis is one of your posterior compartment muscles, so that's definitely not gracilis, definitely not adductor brevis. Now rectus femoris, right? This one is that muscle, and that's the correct answer. Very few people tend to remember rectus femoris, but you should remember it. The two most important big muscles, actually there's three that are the most important big muscles in the anterior area, are your sartorius in the corner right here, rectus femoris, and the vastus guy. Right, there's a bunch of vastuses. They're all right here. So you got to make sure you remember that. That anatomy, not the most high yield stuff. I mean, if you don't remember it yet, and you're only preparing for NBME, it's really up to you. I would definitely say memorize it, because if it's on this NBME, there's a very high chance the same question is going to pop up for a different thing later on. Maybe they might move it around to a different location. So you should make sure you do know this anatomy. Now, when I did musculoskeletal anatomy in my videos and we go to lower extremity, I have pictures from many things to show you where everything is, right? So I have these tables from Netters and these images from teachmeanatomy.com, which do a great job to show you where everything is. And you can see in this area right here, this is the anterior thigh, right? This is a man that's standing looking at us. You can see his anterior thigh, all color-coded. The front here, you have all your vastus guys and the rectus femoris. This is the rectus femoris right here in the yellow. Right, rectus femoris, vastus medialis is medial, vastus lateralis is lateral, right? And then you have the vastus intermedius inside, behind the rectus femoris. We can't see it in this picture. Sartorius going sideways like that and connecting to this tubercle. Right, so it's not the hardest stuff. Your psoas major and iliacus are further behind. They're in the posterior area, behind the butt area. So it's good to know these guys. Now again, these guys are really important to know because they're your quadriceps, right? The quadriceps is 4 important muscles. All of them are vastus except for rectus femoris. So the question that they asked you here, this question here wasn't really that unfair, because you should know your quadriceps pretty well. And if you're working out, then that's another reason you would know it pretty well. Let me just put the page number for myself here. Because I use these same forms when I'm working with students. So just make sure you have a pretty good idea of all of this anatomy, right? And anatomy is something that you're not going to remember just because you studied it once. But having good visuals all combined, multiple different good visuals in the same area, is an excellent resource. This is one of the reasons that my PDF sells really well, because having everything like this, the same way I used it for my own Step 1 prep, has been really advantageous for everyone that bought this book. It's a lot better than just having the plain first aid the way it is, and it's really difficult to utilize multiple books at the same time yourself. I'm a guy with I have 2 laptops and I have a third screen. I have an extra screen attached to this laptop. That's why I'm looking over here, right? So that helps me kind of open multiple books at the same time, and that's something you can do too. But as I was studying over time, I realized I was traveling a lot, so I had to put everything into the same book, because I would always only have one screen open. And this was best. This was the best way to study it. Being able to look at all the anatomy, the veins, arteries, nerves, memorizing the color-coded structures, it helps. It makes a major difference, right? Because, of course, first aid, it teaches you anatomy, but not like this. They don't show you where the muscles are. They don't really show you too much about how the nerves are coursing. They do show you where the nervous system sensations are. That teach you pretty well, but that's about it for the most part. So not a bad question. Not a bad question at all, but you had to remember your quadriceps. Right? So they put 2 guys from your quadriceps, and rectus femoris is the one in this front area right there. Okay. Number 12. Oh yeah, okay, this is a really interesting topic. So let me share the link to learn this. This is the link that you have to go use to learn how this works. Let me show it to you guys as well so you can find it. Okay, so if you need to watch this video, you can either click the link from the chat right now or YouTube intention to treat. This is a topic that NBME is really loving. They've been talking about it a lot, and this video does a really good job showing you like examples of how you would work with it. See, they do a really good job teaching you how intention to treat has anything to do with anything. You might have never heard of intention to treat, and it's actually not in first aid at all. So let's take a look at this question, and then we'll discuss what that means, right? And you can watch the video to learn intention to treat. It's a short video that's very straight to the point. And that guy's channel is pretty nice too, so I do want to give him credit. He has a nice channel teaching you many things. I really want to learn how to do those visual things that guy has in his video too. I can never figure out who or how that's done, like who through that's done or how that's done, because that'd be cool. I'd love to show a couple diagrams in a similar manner like that, but I don't know how that's done. So if anyone does know, please do reach out and let me know. Let's take a look at this question. So an investigator is conducting a randomized, double-blind, placebo-controlled clinical trial of a new medication for the treatment of mild insomnia in adults. A total of 2,000 participants are enrolled in the study and randomized to one of two groups. 1,000 of them get the new medication, that's group 1. 1,000 of them receive a placebo, that is group 2. Right? A placebo that appears identical to the medication, so they know nothing about the medication. So 1,000 get the medication, 1,000 get a placebo, great. Participants in both groups are instructed to take one pill 30 minutes before bedtime each day and to keep a sleep diary. After 1 month, each participant is interviewed and the daily sleep diaries are reviewed. Okay, perfect. That seems like a good design. At follow-up, it is determined that 200 participants in group 1, where they actually took the medication, and 50 participants in group 2, where they took a placebo, did not take the pill as directed. In accordance with intention to treat analysis, how should the data pertaining to all individuals who did not adhere to the instructions be treated? So basically, 200 people that were supposed to take the real medication didn't do it correctly, and 50 people that were taking the placebo didn't do it correctly. What do we do with their data? That's what they're asking. And this is in accordance to intention to treat analysis, right? That's the design of this experiment, intention to treat. So intention to treat, that video that I just linked, does a great job to teach it. The video explains per protocol, as treated, and intention to treat. There's 3 different variations, right? We're doing, in our question, is intention to treat. But the other things are per protocol and as treated. So those names will really make a lot more sense once you learn what they are. Per protocol would only examine the data from participants who were compliant with the methodology. This could improve the results in the experimental group. Right? So it can improve the results in the group that has the actual medications being taken. As treated would examine the data in the group the participants were supposed to conform to, rather than the one they were assigned to. This can improve the experimental group and lower the control group information. And then there's the last one, in intention to treat, which is what we're doing. We keep all the participants' data in the group they were assigned to, and nothing gets altered. Right? This does not alter the data at all. We're just gonna keep the people that didn't take the medications correctly in the same group, and see how things go. That's what intention to treat is about. The most confusing one of these 3 design topics is the as treated, right? Examine the data in the group the participants actually conformed to, rather than the one they were assigned to. So maybe, and that as treated thing doesn't go to this question, but maybe there were 2 groups. In one group, someone was supposed to take the medication every 3 hours, and in another group, they were supposed to take the medication every 10 hours. And some of the 3R people might have done it every 10 hours, so then you move them over. That's what as treated is. So as treated, you put them into the group that they acted out, rather than wherever they were assigned to. Per protocol, if you didn't follow protocol, you get kicked out, right? And intention to treat, I intend to treat you even though you didn't take the medication correctly, so we're going to keep you where you were. That's kind of how I memorized it, especially after watching that video discussing intention to treat. So of all your answer choices, the only one that makes sense for intention to treat is A. Analyze all non-adherent participants according to the group of the study to which each was randomized or assigned to. The wrong answer choices, so exclude all non-adherent participants from analysis. That will be per protocol. You did not follow protocol, so I'm going to have to exclude you. Exclude only non-adherent participants in group 1. Exclude only non-adherent participants in group 2. Those two answer choices don't make sense at all. Like, even if you had no idea what intention to treat, per protocol, and as treated mean, C and D make no sense for what the question is asking. And then the last one, perform separate analyses of the 250 non-adherent participants and the 1750 adherent participants. Again, this also doesn't make any sense because doing this would not really give you any viable data. What are you going to do with the information you get from the 250 non-adherent participants? How does that even help with anything? So performing separate analysis on that would be useless. So you were really between A and B. And intention to treat sounds like such a nice thing. So A is the nice thing to do. Just keep everyone where they are, right? Whereas per protocol sounds very army type, right? If you didn't follow the protocol, you get kicked off. That's what B is. Number 13, an investigator is studying patients with the West Nile virus infection. During a 5-year period, data are collected on 25 patients diagnosed with this condition. During a 5-year period, data are collected on 25 patients diagnosed with this condition as confirmed by testing at the CDC, Centers for Disease Control and Prevention. Demographic information on the patients is reported, so age, gender, and ethnicity, as well as information about the likely sources of infection. Which of the following best describes this study design? Again, another case kind of thing. This is something that you might have not really seen in first aid, right? First aid does talk about case control. This is not case control. You cannot get on choice B, right? This is definitely not case control. We don't have a case and a control to compare it with. This is not a cohort study, right? This is definitely not a correlational study. What are we going to be correlating? We're definitely not correlating age, gender, and ethnicity with sources, right? That's too many things to correlate. This is sort of cross-sectional because it's kind of being done at a certain time period, but at the same time, it's definitely not cross-sectional because this is during a 5-year period. A lot of people wanted to pick cohort, right? But that's not what's happening here. So we go to where this is all discussed. Take a look. So if we look at all these, right, cross-sectional happens at a time and one point in time. Case control is usually in the past. Cohort is towards the future. A lot of people wanted to pick cohort for this study because it's 5-year period, going towards the future, blah, blah. So a lot of people were really, following someone over a long period of time is pretty much how cohort works. And that's not what's really happening here because look at this. Cohort compares a group with a given exposure to another group without the exposure. We don't have two groups. That's the number one thing you need to figure out here. When you look at this, you don't necessarily have two groups. The only group we have are 25 patients with this condition. We don't have 25 patients without the condition or 25 healthy people. We don't have a second group. Since there's only one group, all of these answer choices talk about two groups except for A. A case series, which is not in first aid. A case series is an observational study with just one group. A group or series of case reports involving patients who were given similar treatment. Reports of case series usually contain detailed information about the individual patients. This includes demographic information and information on diagnosis, treatment, response to treatment, follow-up after treatment. In this question, it looks like they didn't really focus on the treatment part, but otherwise, case series makes sense. A correlational study determines whether or not two variables are correlated. This means to study whether an increase or decrease in one variable corresponds to an increase or decrease in the other variable, or are they independent of each other, right? And even if you never heard of case series, you should be able to answer this question because you're able to knock out the other answer choices, and that's it. All right. 14, a 20-year-old man comes to the physician stating that food has lost its flavor ever since he fell down a flight of stairs and hit his head 1 week ago. He says that he feels fine otherwise. Physical exam shows no abnormalities. Neurologic exam is most likely to show which of the following cranial nerve injury. So basically you're seeing a bunch of nerves now and he lost taste, so you need to remember innervation of the tongue. Now that's something that you want to remember correctly forever. So page 535, let me show it to you guys. You never want to mess that up. First things first, remember that facial nerve is for muscles and not mastication. Muscles of smiling, right? Whereas trigeminal nerve is for muscles of mastication. So now if we look at this, right here you can see taste and sensation, right? Taste, the posterior part of the tongue is 9 for both things, right? Taste and sensation, 9. The anterior 2/3 is the harder part. So up here I wrote, since 9 is a bigger number than 5, since 9 is a bigger number, cranial nerve 9 carries both taste and sensation in the posterior 1/3 of the tongue. Since cranial nerve 5 and 7 are smaller numbers, they each carry one thing. 5.3 or V3, the lingual nerve of cranial nerve V3, carries general sensation of the anterior 2/3, just like it does for the entire face, right? Remember, for the face, the smiling and all of that, muscles of the face itself are facial nerve, muscles. But sensation of your face, remember the trigeminal neuralgia, right? That's all trigeminal. Sensation is trigeminal. So that same thing applies to the anterior 2/3 of the tongue as well, right? So sensation of your anterior 2/3 of the tongue is V3. Cranial nerve 7 carries taste for the anterior 2/3 via the chorda tympani. This is all a result of the branchial arch organization. The first and second branchial arches make the anterior 2/3 of the tongue, and they are innervated by cranial nerve 5 and 7 respectively. The third and fourth arches become the posterior 1/3 of the tongue and are innervated by cranial nerve 9 and 10 respectively. And you want to make sure you know that association, because that's how embryology questions often present. So for this question, the answer would just be C, and you would just move on with life. That's it. Really straightforward. Alright, that's it. There's really nothing else to do. You couldn't pick you couldn't pick D. Right? You couldn't pick D because the patient doesn't have any motion issues with the tongue. Right? Remember that cranial nerve 9 would also have both the taste and sensation, right? The back. And he doesn't have issues with sensation. Sorry, not motion, sensation. He doesn't have any motion or sensation. Motion of the tongue is the motor guy, number 12, right? Hypoglossal. So hypoglossal innervation would have been the other thing. But since he doesn't have issues with sensation, you can't pick 9. So his tongue sensation, we're assuming, is perfectly nice. No issues with sensation. His only issue was taste, and 7 is the one that's related to only taste. 9 is taste and sensation, and V3 is only sensation. So make sure you remember this stuff. This isn't that hard. It takes time, of course, just like everything else. But again, none of it is really that hard. It's something that can become confusing because you can study it and you might feel comfortable about it, but then you see it in the question and you don't feel so comfortable. You want to make sure you're past that. You should feel comfortable even when you see it in the question. And here, when you see this question, it should have been really comfortable. So just go ahead and pick C and go to the next question. This one, a 56-year-old man with a 20-year history of chronic back pain undergoes operative placement of an electrode in his midbrain for pain management. Previous physical and neurologic examinations showed no abnormalities. When the implant is activated, the patient reports a marked decrease in pain. Administration of which of the following substances would most likely result in the return of this patient's pain? Okay, this is a really weird question. I remember reading this question and not really knowing what they were talking about, right? So this guy, he has chronic back pain. He undergoes operative placement of some kind of electrode in the midbrain for pain management, right? So it's working with something in the brain. Previous physical and neurologic exams showed no abnormalities. When the implant is activated, he has a decrease in pain. Okay? Administration of which of the following things would result in a return of pain? So basically, which of these guys would cause pain? So this was something I found online on Reddit. It said, I just read it. So the question, I just read it as patients taking opioids to blunt or control pain. So if the electrode does the same thing, decrease pain, then an antagonist of opioids would bring back the pain. IDK of that reasoning is sound, but that's the logic I used. I didn't even think of it as experimental. And truth of the matter is, it works. That is how you were supposed to kind of approach this question. Right, so if this patient was taking opioids to control the pain, and then all of a sudden you gave him an antagonist of opioids, the pain would come back. Right, and that's what they're kind of testing you on in this question, but in a really weird way. Also, note that naloxone is the only opioid antagonist in this list. The others are practically opioids for reducing reducing pain. What did I write? Wait. Reducing pain. Naloxone is also the treatment for opioid intoxication. Right? So if you were using the logical method of which one is different from the others, all of these other medications are opioids or something related to opioids, whereas naloxone is an anti-opioid. So that's the only one that's different, so you would pick it. And it's true, if you gave this patient an anti-opioid and he's had pain before, he's going to get pain again, right? Because he doesn't have any opioids anymore. So that was what they were testing you on, but this question was, really funky, and a lot of people were just very confused when they saw it. It was also intimidating because some people forgot what enkephalins are, some people didn't remember what morphine and oxycodone were, so it's a difficult thing depending on where you are on your study level. Make sure you know what enkephalins, morphine, naloxone, all of these guys are. So page 595. Right here, you have your opioid analgesics. Right? These are all your opioid medications. And the antagonists, opioid antagonists, are naloxone, naltrexone, and methylnaltrexone. Right, so antagonists. And you see enkephalin right here. Enkephalin, beta endorphin, these are all different, even dynorphin. These are all just extra opioid things. Okay. Number 16, a 30-year-old woman develops serum sickness following parenteral administration of penicillin. A plasma sample is found to contain a mediator that stimulates histamine release from mast cells. Which of the following mediators was most likely found in this patient's plasma? So which one of these guys would cause histamine release? So if you've never seen this before, then you would possibly be pretty confused. Yeah, there's really no explanation besides memorization. So mast cells can be activated by tissue trauma, C3a, C5a, surface IgE cross-linking by antigen or IgE receptor aggregation, degranulation, release of histamine, heparin tryptase, and eosinophilic chemotactic factors. Right, this is the whole way mast cell degranulation kind of occurs. So the answer was just C3a. Now, page 106 discusses these complement things, but even though it's being discussed, doesn't mean you'll completely remember it or understand it. However, it does a pretty good job. So you can see how C3a, 4a, and 5a are related to anaphylaxis, and that's how I always remembered it. So the A guys are for anaphylaxis, and that reminds you that that's the mast cell histamine, all of that stuff. Right, C5a is for neutrophil chemotaxis, and you need to remember all the guys that are for neutrophil chemotaxis. C5a, leukotriene B4, right? There's a bunch of others. You need to remember everything together for neutrophil chemotaxis. That's a pretty high yield topic. C3, 4, and 5a are specifically for anaphylaxis as well. The B guys are often for bacteria stuff. Right, so you can see C5b to 9, this is the whole MAC stuff for Neisseria. If you're missing it, you keep getting Neisseria. You're going to have low C3 if you have lupus, and so on and so on. Right, so the inhibitors, this is the stuff, right? If you're missing the inhibitors, you end up getting PNH, paroxysmal nocturnal hemoglobinuria, where you're going to have hemolysis. Right, so that's, then they discuss it on the next page. So just a simple question on that stuff. That's all they did here. 17, a previously healthy 55-year-old man has permanently been diagnosed with hypertension. He has not received any therapy. Lab studies show mild hypokalemia, metabolic alkalosis, and increased plasma renin activity. And aldosterone concentration. Following administration of an angiotensin-converting enzyme inhibitor, the plasma renin activity increases further. Which of the following is the most likely cause of the hypertension in this patient? Alright. So you gave this person an ACE inhibitor, right? So let's look at the explanation. As a rule of thumb, if you give someone an ACE inhibitor and they get a problem, then they most likely had renal artery stenosis, usually bilaterally. That's something you always want to remember. Giving an ACE inhibitor is supposed to get rid of the hypertension. Right? That's definitely another rule of thumb you already have, right? You know this. Giving an ACE inhibitor fixes the hypertension. If you give someone an ACE inhibitor and they get more hypertension, okay, that's renal artery stenosis, and you know the answer immediately, and then you just lock it in as choice E and you move on. This probably has to do with decreased GFR thanks to the decreased angiotensin II selective vasoconstriction of the efferent arteriole. That causes decreased sodium delivery to the macula densa, and you get even more renin release, right? And that's kind of what happened with this patient. Also, you shouldn't be seeing end organ damage or increased renin or kidney response with the previously healthy patient that just developed essential hypertension. All right, so that means that this patient did not just develop essential hypertension. Think about the question scenario. Previously healthy 55-year-old man now has hypertension. So we're thinking, all right, it's probably essential hypertension. He has not received any therapy, and then you're already seeing end organ damage, right? That all of the stuff you're seeing is basically something's damaging the kidney. Why would you start seeing end organ damage that quickly from essential hypertension? You would not. So then you start thinking maybe fibromuscular dysplasia, maybe renal artery stenosis, one of those two things. And the question scenario they gave you of giving an ACE inhibitor and then the renin went up, that's renal artery stenosis. All right. To eliminate the other choices, he has increased renin activity, so you can eliminate primary aldosteronism. That has increased aldosterone with decreased renin, right? No signs or symptoms of Cushing's, so that's eliminated. He doesn't have any high hypercortisol issues. 11-beta hydroxylase deficiency would present with ambiguous genitalia. You would have decreased renin activity, and aldosterone-like effects would still be present, and that's not happening in this question either, so A is wrong. Essential hypertension I just explained above, right? Because if you have essential hypertension, you shouldn't have end organ damage that quickly. So, not a bad question, but really nicely phrased, and if you've never heard of this, right, following administration of an ACE inhibitor, the renin goes up, then now you know. If you give ACE inhibitors and the hypertension gets worse, renin increases, etc., those are all signs of renal artery stenosis. Number 18, a 32-year-old man comes to the physician because of a 3-month history of swelling and tenderness of both breasts. He has been receiving thyroid hormone and corticosteroid replacement therapy since undergoing surgical removal of a pituitary adenoma 2 years ago. He began HCG injections 4 months ago. Which of the following is the most likely binding site and action of HCG that is causing the development of gynecomastia in this patient? Alright, so now, this was a pretty hard question because it threw many people off. But if you look at each answer choice one by one, you can kind of figure out what must be happening. And, you know, of course, most people did pick B. Right? Most people picked B. Most people thought that the HCG went to breast tissue and caused direct stimulation. But that would not be true. That's not what's happening here. So the answer here was E. So this HCG actually went to the testicle and caused more estradiol production. Remember in hepatic failure and liver cirrhosis, you can get gynecomastia there too because you're unable to have the liver kind of break down all the estrogen correctly. Excess estrogen is the thing that causes the breast development, right? This gynecomastia stuff is excess estrogen. So direct stimulation of the breast by beta HCG would not cause excess estrogen. You knock that out. The main way to answer this question was to really think about the fact that the only way a man can end up getting gynecomastia is because of excess estrogen. This is actually a fact almost everyone knows pretty well. And once you see answer choice E, where you have estradiol production, doesn't matter that it says testicle here, that's just there to confuse you. Estradiol production would explain gynecomastia. These other things would not explain gynecomastia. 17-hydroxyprogesterone synthesis does not explain gynecomastia. Testosterone metabolism, no. Prolactin secretion, again, another trick answer choice that many people could pick, except he's already gotten his surgical removal of the pituitary. Right, so it can't be D. Cannot be D. In fact, D was the one as a choice you could just knock out immediately, and you're down to a 25% chance of guessing correctly. So beta HCG, as well as a couple other guys, have the same alpha subunit. So HCG can activate those receptors if it's in high enough quantity. and you see LH, FSH, TSH, and on your breast, if it activated any one of these three guys, how would that cause gynecomastia? There's no explanation for it. That would be the answer you would pick if you're just confused and don't know enough and haven't studied enough, which is respectable. You make sure you learn it now. Activating LH receptors will lead to more testosterone from the Leydig cells. More testosterone can lead to more estrogen formation via aromatase. Right, but not in the breast. That's not going to cause anything. Activating any of these guys in the breast wouldn't really help you, or not help you, but cause you to develop gynecomastia. All right. So really interesting question. Combines a lot of physiology from reproductive chapter, but the main thing was knowing that gynecomastia is generally related to excess estrogen, and the only answer choice that gave you that was E. Number 19. 55-year-old man with severe emphysema comes to the physician for evaluation of shortness of breath. Which of the following findings are most likely on examination of the lungs? Okay, so emphysema and shortness of breath, right? And then you're looking at pulmonary auscultation findings here: percussion, tactile fremitus, and expiratory wheeze. The normal lung has resonance, right? So this patient is not normal. So you can knock out everything from E to H. Having resonance is a normal thing. If you have hyperresonance, that's not normal. COPD would have hyperresonance, which is what this patient has. Tactile fremitus is only increased if there is something solid in the lung, like a tumor. So here, tactile fremitus should be low. So you're between A and B now. COPD is defined by prolonged expiration, which is why you end up having the really bad FEV1 to FVC ratio. So you just pick B and that's it, right? Expiratory phase, prolonged expiration. That's the thing that we know about COPD. If we go to page 733, I have a chart from UWorld right here. Right? Pulmonary auscultation examination. Breath sounds, tactile fremitus, percussion. The normal lung has resonance. Hyperresonance is seen in pneumothorax. Right? Pneumothorax. That's the only one that has hyperresonance. All these other things, consolidation, pleural effusion, atelectasis, these guys have dullness because percussion is something that requires air, right? So let's read this explanation real quick. So tactile fremitus, being the transmission of vibration from vocalized sound, is going to increase if there is something solid present and decrease if there is nothing present to transmit sound waves. Right? So you can see tactile fremitus is only increased in consolidation. Something solid is present to actually help you vocalize the tactile fremitus. Percussion is the transmission of sound from air in the lung, and the resonance is noted when you tap on the chest wall, and that will increase with more air and decrease with lesser air. The only place with more air is in pneumothorax. You have too much air stuck together. Pleural effusion is fluid, consolidation is solid, and atelectasis is a lack of air because your alveoli are popping. So all of those guys have dullness. So you can see how hyperresonance kind of points at pneumothorax, and increased tactile fremitus points at consolidation. Right? The other things don't really directly point at something, but can help you. So make sure you understand how that works. And as far as COPD, yeah, a low FEV1 to FVC ratio is a given thing. So prolonged expiration. Number 20. A 32-year-old woman is brought to the emergency department 20 minutes after she became confused and lost consciousness. 4 hours ago, she fell 5 feet from a ladder and struck the right side of her head on the edge of her desk. Ouch. She felt well enough to continue walking. She's unresponsive to painful stimuli. So, okay, she hit her head, then she lost consciousness, right? Sorry, what am I saying? She hit her head, she kept walking just fine, then all of a sudden she lost consciousness. So she had this window period of being okay. That is a giveaway for a specific kind of intracranial hemorrhage. And they did a good job for this question to try to confuse you, right? Because they started immediately with 20 minutes after she became confused and lost consciousness. How did she lose consciousness, right? They didn't give you the question in a good timeline. You had to put the question into a timeline yourself. Anyway, right now she's unresponsive to painful stimuli. Physical exam shows edema over the right anterior temple. The right pupil is dilated and poorly reactive. The left pupil is normal. Which of the following is the most likely diagnosis? And you look at all your answer choices: arterial laceration, cavernous sinus thrombosis, concussion, ruptured aneurysm, tearing of bridging veins. A lot of people wanted to pick concussion. This is not a concussion. Anytime you have a person who bumps their head, gets back up, and then has severe issues or dies like 6 hours later, you have yourself an epidural hematoma from a laceration of the middle meningeal artery. Golgin really emphasizes that you don't screw up and select middle cerebral artery. You know it has to be an arterial laceration since the dura is tightly adhered to the skull's inner surface. Golgin referred to his experience with it as needing pliers to remove the dura from the skull. Graphic, but it drives the point home. Tenting seen on CT is because the epidural hematoma gets stuck between the suture lines. When it manages to break past one of the suture lines, it is my understanding that is when you get severe sequelae like death or coma and stuff like that. So if we look at page 557, and we recently discussed this in my neuro videos because I've been doing neuropath lately. Here, in epidural hematoma, right, you have rupture of the middle meningeal artery, and that's not hard to remember because the meninges are part of the brain. And that's actually a branch of your maxillary artery. That occurs because of injury to the thinnest part of your brain, right here, thinnest part of your skull, the pterion. And they describe that. They describe that in the question too. They tell you she hit her right side of her head on the edge of the desk. Physical exam shows edema over the right anterior temple, which is right here. Right, so this is the really, really thin part of your skull that connects 3 different bones right there, and it's just really easy to injure. So that's definitely all giveaways for this. She had the lucid interval. Right? She hit her head, she continued to walk, then she lost consciousness. In that lucid interval, this was expanding. Remember how an epidural hematoma kind of looks like, right? So you have your epidural hematoma, which is actual arterial blood from a skull fracture and a rupture of the meningeal artery. Right, so the dura gets pushed away by the hematoma, and you get this, what do they describe it as? Biconvex, right? It's convex on both sides. Whereas this thing, a subdural hematoma, is a torn bridging vein, is venous blood, right? And the dura is attached to the skull. This is under the dura, whereas this one is on top of the dura. That's how they're named, epi versus subdural. When it's above the dura, you get biconvex. When it's under the dura, you just have this kind of crescent moon thing happening. Right? And that doesn't have anything to do with our question. Our question is about the lucid interval. All right. So you get rapid deterioration to the hematoma expansion. It's expanding throughout this area, throughout all of that area. And as it expands, it compresses different parts of the brain, causing the patient to lose consciousness. 21. A 5-year-old boy is brought to the physician for a follow-up exam 1 week after being diagnosed with a genetic defect that has affected his ability to reabsorb substances in the proximal tubule. Which, anytime you see reabsorption issue with the PCT, that's Fanconi. Fanconi means you're not absorbing shit anymore. Serum studies are most likely to show which of the following findings at this time. So it's been a week, so he's definitely going to have bad serum studies. So let's see. Are you going to see hyperalbuminemia? No, we're not absorbing albumin. We're losing it. Are we going to see hyperglycemia? Definitely not. That would be diabetic. PCT is supposed to reabsorb sugar, and you're not going to be able to reabsorb sugar either. Hypermagnesemia. Magnesium is often a very tricky answer choice, so we're just going to skip over that. It's a potentially correct answer choice. Let's see the rest of it. Hypokalemia. That sounds pretty promising, right? Because we lose everything that we're supposed to reabsorb in the PCT. But it's not really a potassium thing. It's more about the sodium, the sugar, and some proteins. Generally speaking, a lot of things besides potassium. But we'll keep that open too. Maybe it's a possible answer choice. Hyponatremia. Again, another plausible answer choice. And then they put hypophosphatemia. Now, phosphate is a really big deal, right? Because phosphate is related to bone and calcium and all of that other stuff. And phosphate and calcium are also related to magnesium issues with PTH. In Fanconi, with PCT reabsorption issues, you will have hypophosphatemia, So if we go to page 636, we can take a look at what we're talking about in renal. Alright, so Fanconi's PCT, increased excretion of amino acids, glucose, bicarbonate, and phosphate, and all substances reabsorbed by the PCT. And some of these substances also include sodium and potassium. However, in other parts of your kidney, you will manage the sodium and potassium. That's what you were supposed to think of, right? The PCT isn't the only part where sodium and potassium are managed. So hypokalemia and hyponatremia, although plausible for things that can occur from the PCT, these things would be managed by the other parts of your kidney, right? The DCT, the other loops of Henle and all that stuff. So hypokalemia and hyponatremia would not be present in this patient as a systemic human. But hypophosphatemia would be. Right? Your PCT is the main area where phosphate reabsorption occurs. And if you don't reabsorb it, you just pee it out. The PCT is the only guy that does it, right? In the kidney. So hypophosphatemia was the answer here, and that's it. Also want to make sure you see here, right? You can see that the bicarbonate stuff is related to the PCT, right? But again, you're not going to pick, well, they didn't even have it. They don't have a bicarbonate acid choice here, so that works out. That's not a problem. Let me see, is there anything else? Yeah, you can see the sodium and potassium and stuff, but again, sodium and potassium, the DCT and many other parts of your body take care of it too, so that's about it. And remember, the PTH works on the DCT. Even though PTH works on the DCT, it is your PCT that manages phosphate reabsorption. 22. A 24-year-old man comes to the emergency department because of an 8-hour history of abdominal pain, nausea, and vomiting. He takes no medications. He has a family history of pancreatitis and hyperlipidemia. His temperature is 98.6 F, pulse is 110, blood pressure is 125/88. Abdominal examination shows mild distension and diffuse tenderness with no rebound tenderness. Bowel sounds are decreased. Serum studies show a glucose concentration of 90. Triglyceride concentration is super high. And lipase concentration of 400. The serum appears milky, which is a giveaway for the answer. The most likely cause of this patient's condition is a deficiency of which of the following. So you look at your answer choices and you know right away this is your familial dyslipidemias, which is a very high yield topic on NBME. They love asking you questions on it. Familial dyslipidemias take about a day to memorize. You can memorize it and you'll never forget it again, and this is how you memorize it. So we go to it real quick. Because you should be able to talk about it without having to look at it in the book. That's the point you want to get to. So always first remember A beta lipoproteinemia. The blood smear is going to show acanthocytes, and in A beta lipoproteinemia you don't have the beta, right? So you're missing ApoB48 and B100. If you're missing them, you end up running out of chylomicrons, VLDL, and LDL. The mutation is in a microsomal transfer protein. You have to remember that. This can be one of your answer choices. So what happens? The infant presents with fat malabsorption, steatorrhea, failure to thrive, and then many other symptoms related to fat-soluble vitamins that he lost. How do you treat it? Don't give him long-chain fatty acid foods, and give him the fat-soluble vitamins he's missing. That's it. Excuse me. So now, familial dyslipidemias, this is how you kind of memorize it. Number 1 and 4, these are the two guys that have high amounts of triglyceride. Okay, number 1 and 4. And because of the high triglyceride, both of them can cause pancreatitis, which we're seeing in our question. In our question right now, this guy has high lipase, right? He has the pain, abdominal pain, diffuse tenderness, but not rebound tenderness, because rebound tenderness would be the, what do you call it? I forgot the thing. But rebound tenderness would be the little thing in the corner of your ileum. So that's not what's happening to that patient. And you know that's not what's happening to the patient because none of the answer choices are related to that. And then the serum being milky, that's the thing about the creamy layer in supernatant. So you know that this patient has type 1. Type 1, I write it right here. Type 1 is related to LL or C2, lipoprotein lipase, or C2, which is a cofactor for lipoprotein lipase. The numbers 2 and 3, these two guys, hypercholesterolemia and dysbeta lipoproteinemia, these two guys have high amounts of cholesterol. So they have high amounts of VLDL and LDL. VLDL and LDL are things that cause the atherosclerosis to occur. So you can see that, right? Accelerated atherosclerosis may have an MI before age 20, which is really, really young. Like imagine an 18-year-old with an MI. Same thing with this beta lipoproteinemia. The familial one is known to have the Achilles xanthoma, which is a very common thing you get questions on. So how do you memorize number 2? Number 2 is ApoB100. Right? That's the way I remember it is. I would just think of so when I was studying, it was weird, but I think it was because 2 times 50 is 100. I made up this weird thing. There's no real way, but the 3 is easy. 3 is ApoE, so you can remember 3 and E ending together like that. 3 is ApoE. E for everything. ApoE, apolipoprotein E is the one that reuptakes everything. If you don't reuptake everything, you leave out a lot of chylomicrons in VLDL and LDL and IDL, all of that stuff, causing atherosclerosis. Type 4 is 4 letters, right? 4 letters, hypertriglyceridemia, 4 letters of VLDL, which is just the triglyceride one. VLDL and TG. The issue is, though, VLDL. If you get a question, the answer choice is going to be this: hepatic overproduction of VLDL. But you don't see atherosclerosis here. Here you're going to have too much triglycerides. And anytime you have too many triglycerides, too many VLDLs in general, you have the diabetes stuff, right? Because adipose causes insulin resistance. You have to spend a day, just a day, spend a day, memorize the hyperlipidemias or the dyslipidemias, and you'll know them really, really well. Because once you memorize them well and you know the differences between the 4, including A beta lipoproteinemia, when you get questions like this, it's a giveaway and you don't have any issues. No issues. You know immediately that this guy has the type 1. The type 1, you should have a visual memory of this page 2 the best you can. 1 is the creamy creamy layer in the supernatant. 1 and 4 are the ones with the pancreatitis. 2 and 3 are the ones with the atherosclerosis. Alright, so number 1, you're going to remember as soon as you see the creamy layer. They usually don't give you the creamy layer in the question. As soon as you do see it, though, you know it's lipoprotein lipase and you're done. Right, so the patient has symptoms of type 1 hyperchylomicronemia, which is autosomal recessive. Type 1 and 4 have high triglycerides and pancreatitis. Type 4 is autosomal dominant. It would be related to hepatic overproduction of VLDL, not a deficiency of some receptor. ApoB100 is missing in type 2, which has high LDL and atherosclerosis. ApoE is missing in type 3, which has VLDL and atherosclerosis. Also, their dominance is different too. The even number ones are the ones that are autosomal dominant. So the even numbers. Takes a little bit of time, but I assure you, 1 day of just dedicated studying to that, and you're going to have it down perfectly. 23. A 15-year-old girl is brought to the physician by her mother because of a 1-day history of a rash in her face, arms, and legs. Okay, she first noticed the rash 5 hours after she spent time at the beach on a sunny day. She has been receiving antibiotic therapy for acne. Physical exam shows diffuse erythema and mild edema over the face and extremities. Which of the following antibiotics is the most likely cause of these findings? So she basically now has photosensitivity because of an antibiotic, and the only antibiotic that causes photosensitivity of all of these guys is doxy. And you might not actually remember that. Right? Very few people tend to remember that. People remember that tetracyclines are not good for kids. People remember that it causes bone issues, and that is contraindicated in pregnancy because of that. The other things tetracyclines cause are GI distress and photosensitivity. Right? And on top of that, you also have to consider which of those antibiotics can you even use for acne. So tetracyclines are also used to treat acne. Right? So really a nice question to help you remember that, I guess, because you can't really use any of these other guys for acne. Linezolid is a very powerful antibiotic. So that's definitely not one of the answer choices. Ciprofloxacin and azithromycin are not medications you use for acne. Doxy is. Doxycycline is a tetracycline that binds the 30S subunit and is used off-label for treatment of acne. Can cause discoloration of teeth and is known to cause photosensitivity as well, which is what this girl had. Number 24. A 20-year-old man is brought to the physician by his mother because of bizarre behavior for 6 months. Although he had always been a good student, he failed all his classes at college last term. He no longer showers or shaves, and his appearance has become disheveled and unkempt. He appears distracted at the beginning of the interview and then begins talking non-stop to unseen people in the corner of the examining room. His mother looks upset and says, "It seems as if he's hearing voices all the time now. He's really scaring our family. Which of the following initial responses by the physician is most appropriate? So now, yeah, you can ask anything you want. You can always email me too. So, when you, okay, and then which of the following initial responses is the most appropriate? So when you get a question like this, keep in mind that this is not about what you think is best. It's about picking the answer choice that's the most sensitive. You want to assume people are very, very, very sensitive. So although something you say might not have a certain implication or something, they might get offended or they might feel bad. You never want to say something like that. So let's go through each one. A, he must be schizophrenic. Does schizophrenia run in your husband's family or yours? Well, right now, what did she just say? She said, it seems as if he's hearing voices all the time now. He's really scaring our family. How can I give I mean, it does look like he's schizophrenic, sure. But I'm not going to just throw the diagnosis at her and then start asking her about, does anyone else in your family have schizophrenia? Without first addressing the fact that she's talking to me as a human about something that's scaring her family. Right? So A doesn't address that. B, he needs to take a shower. Have you tried sitting down with him and talking to him about taking better care of himself? Okay, first of all, he's schizophrenic. Like, you know that as a doctor. So this isn't going to help. Like, yeah, sure, he needs to take a shower, but sitting down and talking to him isn't going to resolve anything. And we still have not addressed the statement she made. C, how frightening for you to see your son like this. Do you have any idea about what might be causing his behavior? That's very open-ended. I'm not establishing a diagnosis straight to the mother. I'm also referring to something she said. She said it's scary, and I'm like, yeah, that is scary, right? That is frightening. I'm sorry that you have to go through something like that. How frightening for you to see your son like this. Do you have any idea what might be causing his behavior? And then she might say, yeah, he's been taking certain drugs, so it might not be schizophrenia. Right? So you have to keep it open. You have to keep it very open. So that looks pretty good so far. D, I'm concerned he might be on drugs. Do you know anything about his friends? Again, doesn't really refer to the statement she made, nor does it really help, show empathy. E, was he under any unusual stress at home or at school, or did he have any problems with a girlfriend when all of this started? Again, yes, appendicitis. Thank you, Vanessa. That question we were looking at, man, where was I? Oh yeah, I think I pissed. Oh yeah, tenderness with no rebound tenderness, right? So the rebound tenderness not being there, you knew it was not appendicitis. Thanks a lot for pointing that out. I just couldn't remember that word. Yeah, okay, so when you get answer choices like this, right? Again, this is another scenario where you can convince yourself into thinking something is the correct answer because you might feel that way, even though it's not correct. And then you might even prove to yourself, yeah, that sounds perfectly fine. It's open-ended, blah, blah. No. These responses, first and foremost, need to, you're responding, right? You're not making a statement. You're responding to something someone else said. You're reacting. So you need to make sure that what you say back does point out or refer to something that she said, right? And the mother said, he's scaring our family. He's scaring our family. You need to make some kind of comment on that, and not a bad comment, not a haha that's so hilarious kind of bullshit comment. No, you got to be empathetic. And on top of that, you want to keep it very open-ended. You're not going to just go ahead and give a diagnosis just because you're so professional. You've been a doctor for 15 years now, etc., etc. You know your shit. No. I mean, yes, of course, more than likely it is schizophrenia, but we still need to ask these open-ended questions just to make sure that it's not. It very well might not be. Maybe he's been doing drugs. Maybe he's going through something very simple, a short-term psychosis just because of some kind of breakup or something. So answer choice E was the other plausible answer choice many people wanted to pick, which I understand how this could be an open-ended question, but it does not refer to what she said. He's scaring our family. You have to make a comment about that. All right. So it's all about just being human rather than just being very systematic. Last question for this video, then I'll be back after some lunch. A 35-year-old man comes to the physician because of a 6-month history of burning abdominal pain that occurs 1 to 2 hours after he eats. He also has had black stools for 2 days. Use of over-the-counter antacids and histamine receptor blocking agents has not been effective in relieving his symptoms. He is sweating profusely and has lightheadedness when he stands. His blood pressure is 105/70 while sitting. Physical exam shows epigastric tenderness. A CT scan of the abdomen shows a 1 centimeter mass in the pancreas. Immunohistochemical labeling of neoplastic cells in a biopsy specimen is most likely to involve use of antibodies directed to what substance? And you see all your answer choices. So, burning abdominal pain that occurs after eating, right? That's a giveaway. There's a difference between pain after eating versus pain before eating. People that have pain after eating, they often also start losing weight because they stop eating. There's a huge group of people that have pain or lack of pain. They have pain when they're not eating, right? So they have comfort after eating and they gain weight. So that difference is really important to know. Let's take a look at that. That really depends on where the ulcer is and what's released out of that ulcer. Okay, well, Zollner-Ellison is here, but I want to look at GIT. I think it is GIT PAT. Yeah, right here. So if you have a gastric ulcer, right, that means that the ulcer is in your stomach. So when you eat, you release acid, right, and that causes you to have pain that's greater with meals. If your pain decreases with meals, right, then that means that you have a duodenal ulcer, right, and that's because when you eat in your duodenum, you release bicarbonate, which is alkaline, right. So the difference is between acid versus alkaline. Now in this patient, they tell you that there's a burning abdominal pain that occurs 1 to 2 hours after eating, and using any of these guys hasn't helped. So this is a weird scenario, right? This is very unorthodox, I guess, because they're using anti-acid medications and the pain still didn't go away. So at that point, you start thinking this might not be a gastric ulcer per se. Sweating and lightheadedness, the low blood pressure, epigastric tenderness, and then a 1 centimeter mass in the pancreas are all giveaways for a whole different scenario now. Immunohistochemical staining being the topic of question should really help you understand this is Zollner-Ellison syndrome, which is a gastrin-secreting tumor of the pancreas or duodenum. Stain the neoplastic cells, which are all releasing gastrin. Right, so that's what the question was about. What are you going to be staining for, or what are you trying to catch with antibodies? Gastrin, and that's what's actually being released by the pancreatic mass. So although the question might seem confusing at first, and you can definitely lose yourself while trying to get the question right, it's actually a pretty easy question, right? Also, you don't really often test for any of these other guys. Like lipase is the only other thing really for pancreatitis, which this was not a question of pancreatitis. Yeah, that's really it. Remember, GIT is one of the easiest system chapters in all of first aid. You want to make sure you know GIT really, really well and not get a single GIT question wrong, except maybe a pharmaceutical one, but the pharmacology of GIT isn't that bad either. Right, so this was just Zollner-Ellison syndrome. It was really clear, and the fact that antacid medications were not working meant that your acid is being released from somewhere else, and that's the thing. Because if you give omeprazole or H2 blockers, stuff like that, those guys are supposed to work on the stomach. If your acid is coming out of something else, or someone else is releasing gastrin, that's your pancreas here, then all those medications won't work on that. Alright, so we'll stop here now, and then in the next video I'll continue on and finish up NBME 20 starting at question 26.